Hi. Hello, welcome to Knock Knock Hi with the Glaucomfleckens. I got the one and only Kristen Flannery, also known as Lady Glaucomflecken here,
And then there's you.
and me. You got
Will Flannery, Dr.
Dr.
Glaucomflecken
Glaucomflecken,
himself.
Dr. G, Dr. Glaucomflocken. I've also gotten Dr. Glockenspiel
That
once.
one's my favorite.
Dr. Glaucomaflecken. It's really endless.
It's your own fault for choosing the word.
Yeah, could have done something a little easier. Anyway, we got a fascinating show today.
Yes,
Had
very,
a
very interesting.
Conversation with Dr. K. Jamison. But before we get to Dr. Jamison, what's going on with us? I just got back. You got to solo parent for a couple
the
days.
weekend. Yep. That
While
was fun. Yep.
While I was off at a neurosurgery conference. My first neurosurgery conference.
You know, you have the hair for it right now.
That's neurology.
I know, but it's close enough.
It's
They're
I do.
brothers.
So here's the deal.
They have the same hair.
I am way overdue for a haircut, everybody. But my and this is a little extra of me, but I'm very attached to my hair person.
Well, as we all are. When you find a good one for you,
Right.
you stick with it.
I've never had a bad haircut from her, and she is on maternity leave.
Yeah.
And so I've already asked her to just, leave the baby or bring the baby with her.
Leave the baby.
Don't leave the baby. Bring
Just
the baby.
abandon your child.
I will hold the baby while
Oh, you would love that. You always have baby fever. You love a good baby.
I love a good baby. So anyway, I am why are we even talking about? Oh, I'm due for a haircut.
Yeah.
And I do have neurologist hair, but this was not neurology. This was
I understand the
neurosurgery.
difference, but they have very similar hair, your two characters.
And in my videos, they are brothers.
That's what I'm saying.
I mean, they could all be related to each other.
Maybe
but
they are.
No, that's too much.
You don't know.
I think I do know.
Not
I'm
even
creating
you.
this universe
No,
myself.
all of the
okay?
world building in this place.
It's all up in my head. I got it. It's there. But anyway, I was in LA, staying right next to the crypto center where there were like playoff games going on, which is kind of cool. But
did you see anybody in the games?
I did. I saw in the elevator, there was somebody.
Always the elevator.
In the elevator, there was a member of the Memphis Grizzlies who was on the elevator with me. So.
And
Yeah.
did you know that ahead of time?
No. Well, he got on. I didn't get a good look at him. All I knew is very tall.
Right. That's what would
Extremely
have
tall.
given it away.
But it was a great conference. It's fun going to these different conferences because I get a little sense, a much better sense of what people are like, what these specialists are like.
Out in the wild.
In the wild. One recurring theme, though, is that there are certain specialties that you have this perception of them as being kind of angry and mean. So like cardiologists, I'm always talking about that. Neurosurgeons, just surgeons in general. But across the board, whenever I go to a conference and I hang out with these people at a conference, everyone is so happy. It's almost like being in the hospital makes you miserable.
Oh, imagine that.
It's amazing.
Yeah.
Everyone is so happy to just be socializing, not thinking about work.
Maybe having a few beverages, some good meals.
Even neurosurgeons.
Going to sleep at night.
Even neurosurgeons, who I just assumed it would take some kind of Herculean effort to get any neurosurgeon away from the operating room into a conference. But it was a good turnout, and it was a great experience.
Did any of them have those baby monitor, nanny cam things where you can watch your baby sleeping? Did any of them have those set up for their operating rooms while they were gone? So they could
absolutely.
keep an eye on
Actually,
it?
yes, to make sure that general surgeons didn't take their operating time.
Yeah.
No, they didn't do that. But I did kind of expect there to be in the exhibit hall, there to be an emotional support operating room for people. Yeah, they could just go to just
feel
in case.
Comfortable, right?
Yeah, at some conferences they have little puppies you can play with.
Yeah. Sensory chamber,
exactly, just like a little operating room, like a fully functioning operating room. You just put on some scrubs and go sit there and pretend to be in your happy place.
Yeah.
I don't know.
But no.
Nope, they did not have that.
Well, business idea for someone out there.
There you go. That's you guys could do that. The AANS and others. All right, let's get to our guest. So we have Dr. Kay Redfield Jamison. She's a professor of psychiatry at the Johns Hopkins University School of Medicine and is a prolific author and
Yes.
just a wonder. So it's very good. She's written several very famous books. The first of which was An Unquiet Mind, which was published back in the 90s. It was about her experience with bipolar disorder.
Yeah, I actually had it as assigned reading in college,
Yeah.
in what was then called my abnormal psychology class. I don't know if it has a different name nowadays, but I remember that book really, along with the rest of the reading list, it really made an impact on me in terms of like thinking about mental illness and destigmatizing it and thinking about it as a biological thing that's happening and how it must affect everyone's lives and what it's like to have to experience that. It was very interesting.
Very influential book as well, and she's been at Johns Hopkins for decades and is a staple in the psychiatry department there. And
Mhm.
so it was a wonderful to talk with her. She is just one of the leading academics on mental health and mental illness. Dr. Jameson also has a new book out called "Fires in the Dark: Healing the Unquiet Mind." So we'll be talking a little bit about her new book as well. A fascinating book about the basically the cultural history of the treatment and healing of mental suffering. And so let's get to our conversation with Dr. Jameson. All right. Well, it's just such a pleasure to welcome you, Dr. Jameson, to the podcast here today. Thank you for joining us.
Sure, delighted.
I'd like to start off by talking about your very influential work, An Unquiet Mind, which you wrote back in 1995, I believe.
Right,
What were you doing from a professional standpoint at that time in your life? Because right now you're at Johns
I
Hopkins. Where were you at that point?
right. I was a professor of psychiatry at Johns Hopkins. Yeah,
Oh, okay. What year was it when you started working at Johns Hopkins?
87, 1987,
Oh, okay. And
the last
and
ice age. Yeah,
And so, you were working as a psychotherapist at Johns Hopkins, and at that time,
yeah. I was a researcher and teacher, and uh,
yeah.
there. Yeah.
And what was it that prompted you to write such a personal account of your own mental illness?
Especially at that time. It's gotten a
Yeah,
little more common now, but at that time, I'm sure that was not very common.
No, it really wasn't very common, and you've got me why I did it. I mean, I did it a lot because people weren't doing it, I suppose. And bipolar illness is a bad illness to have, and I think like all mental illnesses, it makes you feel very alone
Mhm.
mhm.
and uninformed, and like there's nobody else that has this particular problem. So I wanted to write a book about, how difficult it was to live with it, but also that you could get through it.
Were you nervous about publishing that, given the climate around
Insanely
mental health?
nervous.
Yeah,
Well, yes, and for professional reasons, I was absolutely.
Mhm.
It's one of the few times in my life I'm not anxious. I'm inclined to moods, obviously, but not anxiety. And I was really anxious. My
yeah.
I was about uh, you know, mainly privacy. You don't
Mhm.
Mhm.
go around talking about these things. You certainly did then, but also professional reasons. I didn't. I have licenses and I had hospital privileges, and I didn't know if I would still have a job, and what would happen.
That was incredibly brave then. I mean, to potentially be sacrificing all of that in order to publish that book, that's amazing.
What was the reaction to from your medical colleagues, from the people you interacted with on a day-to-day basis?
I would say overwhelmingly positive, with a lot of horror lobbed in. My When I went to the chairman of my department at Hopkins, and I started saying, "Oh, I don't want to put Hopkins in a difficult position. There are legal issues, there are ethical issues, there are teaching issues, clinical issues." Um, but I did feel like it was important for people to know that professionals suffer a lot from mental illness, and that it was good to be open about it. And he said, Kay, you have it all wrong. You have it absolutely backwards. When Professor Halstead, who was the first chief of surgery at Johns Hopkins, uh, when people in the faculty knew he had a cocaine addiction and a morphine addiction,
Mm,
and Osler, who was chair of medicine at the time, said, basically, I have your back, and the faculty took it upon themselves to make sure that Halstead could continue to practice when he was well and to
mm,
teach young surgeons. And he said, if Hopkins can't do that for you, Hopkins has no business being a business. So he gave me the support of a great
That's
teaching hospital.
amazing.
He sent me off to have lunch with the president of Hopkins Hospital, who said exactly the same thing. If anybody gives you any trouble, I want to hear about it.
yeah,
So now this is not, trust me, this is not typical of medical schools around the country. It was
right.
atypical but exemplary.
Yeah, that's a really incredible example and ahead of their time.
Dr. Halstead, you mentioned Dr. Halstead, who is, I believe,
Right.
credited for the um, the outrageous working hours that were kind of thrust upon residents and medical trainees for years,
Yes.
so it's certainly I feel like we've come a long way, in terms of understanding those pressures and that it's not good for mental health, physical health either.
Certainly true. On the other hand, he also introduced rubber gloves and uh,
So he wasn't all
so,
bad. That's what we're
Yeah.
trying to
Well, I
say.
no,
love
no,
I
on the contrary, but, I think and that was his standard procedure, being brutal to
Right,
house staff. Yeah.
right.
Yeah, and I love that this ties into just, the the complicated messiness that it is to be a human being, right? We like to have these narratives of there's good people and there's bad people and there's good things that happen and bad things that happen, but in reality, people are just people and we all are multifaceted and have, good things about us and quote bad things about us and it's about finding that balance between the 2. It's not about, deifying one and vilifying another.
No, absolutely, and it's a legacy in medicine. If you got rid of all the people who had been outrageous, you would
Yeah.
lose an awful lot of people, who,
That's
I
true.
mean, Halstead trained Harvey Cushing. Cushing was
Yeah.
no gentle pussycat, but he also went into the brain at a time when nobody would. And, so there are, and in the arts, I mean, certainly not just medicine, is in the arts and rest of the sciences.
Yes, I
Yeah.
just returned from a neurosurgery conference where I
Uh,
spoke there, and Cushing's face is all over the place, and so
yes, yes,
certainly
yes.
these people had just a huge influence on medicine. But you mentioned the anxiety you had, the fear you had in
Yeah.
coming out with your story and your illness. Uh, but much to your surprise, it sounds like the response was understanding that you got from the people in your life. Were any
Well,
of your
I would say,
fears? Yeah, I was gonna ask if any of your
yeah.
fears were actually came to light.
Oh,
Did you?
for sure, for
Yeah.
sure. Yeah, I mean, I think I had the support of my department. I had the support of my colleagues. I think mostly. There
Hmm.
was a certain amount of very uncomfortable silence. It has to be said. That people, once you've written that you've been psychotic and manic and done inordinately embarrassing things and you've tried to kill yourself, this creates a certain discomfort in some
Sure.
people, to say the least, and for probably for good cause. But I think it, by and large, in my medical colleagues were terrific. So definite exceptions. I think the general public, for the most part, too, was wonderful. But There are a lot of people, when people talk about stigma,
Mhm.
I got hundreds of letters basically saying that I would die in hell, I would live in hell for the
Mm.
rest of my life.
Mm.
That I had sinned if I'd prayed enough, often enough, well enough. I wouldn't have had bipolar illness. There was a lot of vitriol out there, and
Wow.
there's a lot of fear and um, ignorance. And
Mhm.
I
Yeah.
was on the receiving end of it, a lot of it.
Were you seeing patients at this time? Were you did you have an active,
Practice?
practice?
I did. I had a considerable practice in Washington, which is where I was living and
Mhm.
commuting to Hopkins. And I loved it, and I loved seeing patients. But I talked with a couple of my colleagues and asked them their advice about whether they thought it was a good idea to continue seeing patients. And basically, they said no. And I
Mhm.
think that that was good advice for a lot of reasons.
Yeah. Um, it's interesting what came to my mind talking about all the letters that were sent to you, just really nasty things, being told to you was in my world, in this day and age, it's social media, right? So
Mhm.
if if you go public with an illness, I'll just use myself as an example. I had a cardiac arrest and a couple of cancer diagnoses, which is very different than obviously a mental illness. But I do think that the way times have changed now is that it would be a much more immediate public reaction to, coming out with a mental illness, and I have to think probably a little bit more positive than it
Mhm.
would have been, in the '80s or '90s. Do you feel like we've come a long way in terms of just accepting mental illness and just the immediate reaction that people have to it?
Or do it or no.
Or
It's
no? Yeah,
it
yeah. Do we have a long way to go?
yeah, I would say, okay, I would answer both of you, yes and no.
Yeah,
Yeah.
Sure, I think people know a lot more than they used to. The very fact that Prozac arrived, in a manger and everybody thought this would solve
yeah.
all psychiatric problems was really a good thing. I mean, completely oversold it. It was, drug company hype, whatever. But it
Yeah.
was a drug that worked, and people started talking about depression, and that was a really good thing. And so all the times that people used to, haul you over in the corner and say, "I have a friend who's depressed," all of a sudden we're talking about their own depressions much more openly, and I think that's been a good thing. And I think that people do know more. I mean, that the fact that there are a lot of medications out there that work, that people have more comfort talking about psychotherapy probably than they used to.
Mhm.
I think what's happened is, in a way, it's gotten a lot mushed up so that mental health is become mushed up with mental illness. So in some ways,
Mm.
that's probably a good thing because it takes away some of the stigma. In other ways, it takes away from the fact that these really are illnesses and
Mhm.
it trivializes them. So it's
Mm.
we run the risk in a way of trivializing very bad illnesses. So I think
Mhm.
it's complicated. I think one good thing about the pandemic, not a whole lot of good things you can say about it, but one good thing is that people had their kids around them a lot and saw there's a lot of disturbance out there and it's real, and that there just aren't enough psychiatrists and psychologists anywhere
Right.
around.
Right. Absolutely. Yeah, it's really hard even in a metro area like where we are, it's hard to find anyone that has openings even now,
Right,
even 3
right.
years in.
Yeah, and
Yeah.
in your most recent book, which we'll talk about here in a little bit, you talk about kind of the state of psychotherapy, kind of where it is today, and uh, the idea that there's therapy, but there's psychotherapy, but there's also medication, and um, that it's like it's kind of a balance between the 2, right? That they complement each other. Do you feel like we're going in the right direction in terms of how we are treating mental illness, in terms of finding that balance?
Probably not. I think that, for like clinical depression, the evidence has
Mhm,
been pretty clear for a long time that the combination of psychotherapy and medication is better than either one alone. So that's been around just in the books. I mean, and in the scientific literature, the clinical literature. Um, if you look at clinical practice, psychiatrists just end up spending a lot of their time prescribing drugs, which is not hugely interesting. It's not why a lot of people went into psychiatry. People went in
right.
because they were interested in life stories and making people suffer less and so forth. So I think that insurance companies don't cover psychotherapy very much. It's expensive.
Mhm,
Medications are much more seen within the medical model.
mm,
So I think, again, I think it's a mixture. I think people have more favorable feelings about medication, which is great because the hurdle before was getting people to acknowledge that there was something good for medication. I think we've perhaps swung too far and not acknowledging how important psychotherapy can be.
Mhm.
yeah, and I'm sure the time constraints that people have now, with our healthcare
Sure.
system make it even more challenging.
Right, so much
Right.
faster and easier just to prescribe a pill or just to take a pill than, spend the time to.
Well,
Faster,
yeah.
cheaper, and
Yep.
also, and one of the things that again that came out of the pandemic is that um, at Hopkins we're studying telepsychiatry, and I thought, well, yeah, sure, patients may well cotton on to this and like it better because they
Mhm.
don't have to drive into East Baltimore. They park the
Right,
car,
especially if you're depressed, I
salvage their
mean.
day. Yeah,
Yeah.
yeah, exactly. Or anxious or anything,
Yeah.
or normal. But the problem I thought would be with the doctors, but it wasn't the doctors. The doctors actually liked telepsychiatry a lot. And
Oh,
that
really?
says,
Huh.
and that's really quite wonderful. Once they got over, I mean, Hopkins does a very like 3 or 4 hour, very systematic evaluation in person, and that I think everybody regarded as you couldn't exchange that. But what's beyond that, that you could do a lot of psychiatric practice, and people found it more satisfying than they reckoned.
I'm so glad that there are specialties that really embraced telemedicine, because it was miserable as an ophthalmologist, I'll tell you. It's
Well,
maybe one of the worst things I've ever had to endure is
yeah,
trying to diagnose eye problems over a at times pretty terrible
yeah.
internet connection. So
Yes. Well, I mean, as I mentioned, my husband's a cardiologist, and I mean, the idea of doing
Right.
telemedicine is like, you know, and well, I'll do your heart next. I mean,
certainly works for some
uh,
specialties better than others.
Yep.
But I wanted
right.
to talk a little bit more about your personal experience with bipolar, with manic depression. Because I feel like there's a lot of knowledge, there's a lot of, you go on social media, you see a lot of people talking about mental illness, and a lot of it's surrounding, depression and burnout and anxiety. Tell us about mania, because I think that is something that's not really well known in terms of the symptoms and what that looks like. And so, can you just give us a little bit of your experience?
Sure. I mean, mania is actually like depression has been described long, long before Hippocrates. So it's been around forever
Mhm.
in really good clinical description. So it's particular kind of fiery madness. And if you think of depression as being a uh, completely sluggish state, no energy, um, low mood, self-loathing, incapable of thinking, not just rationally, but thinking at all, just confused, ruminating, and so forth, like a hamster
Mhm.
in a wheel, suicidal. Mania is almost the opposite in the sense that people's mood usually is elevated, expansive, high, euphoric. People feel at one with the universe. They feel like, commune with God or our God, depending on the stage of mania. Um, and it's a but highly irritable, highly volatile
Mm.
state, high
Mm,
energy, high voltage. So people have just limitless energy. They stay up all night. They don't sleep. They go without sleeping night after night after night. They are impulsive, occasionally violent, and assaultive. They talk nonstop. They talk very rapidly.
mm,
They are irrational about purchasing things. I mean, mania is the only illness in medicine where there's a one of the diagnostic criteria is spending too much money.
Mm.
So
hmm,
that's actually one feature of mania. And in fact, if you get a group of people who have been manic in a group, very often the old war stories will center around, well, what outrageous things did you buy, and how
Right.
did you pay
yeah.
them off, and whatever. So but it's a hyper state. It's very often confused, and not uncommonly, and understandably sometimes by the police as being a drug induced state. That you're
Sure.
Oh,
on
yeah.
amphetamine or cocaine or so forth.
Mhm. Is it I know you talk about you have another book about exuberance, which exuberance feels very positive to
Yes,
experience. Is
right.
mania similar in that way or different?
Um, it's similar in its mild forms. The
Okay.
trouble with mania, I mean, if you could keep mania in its mild forms, you know, everyone would sign up for it in a heartbeat,
Right.
right? I mean, it's like, who wouldn't want
It's like
more
a
sex?
constant good
More.
mood.
I mean, you'd have to be
Yeah.
pretty disturbed indeed not to want that. And that's kind of a hyper form of exuberance. But the trouble with mania is that it becomes really pathological and
Yeah.
Mm,
psychotic. So most people who have stage 3 mania, for example, hallucinate, have delusions,
Mm.
are incredibly reckless.
Do we know anything about I'm not in medicine or attached to the medical field in any way except that I'm married to an ophthalmologist. That's it. So maybe you guys already know this, but do we know anything about the neurochemical, underlying mechanisms of depression and mania? And are they the same mechanisms or are these two different systems? Or what do we know about how that's working on a biological level?
Um, well, we know first and foremost with bipolar illness, it's genetic.
Okay.
So it's one of the most, next to autism, one of the most genetic illnesses in psychiatry. It's really highly heritable.
mm,
Um, so if you raise, identical twins, and one twin is raised with non-biological parents in LA
Mhm.
and another in Copenhagen, which is kind of the gold standard of genetic studies, you find that there's like 80 to 90%. If one twin has bipolar illness, the other twin likely so.
oh,
Uh,
wow.
Mhm.
it- what's a bit confusing is that in the old European literature, people thought of manic depressive illness as also including recurrent depression. So what we know is people who never showed mania, in
Mm,
fact, who have very recurrent depressions, look much more genetically, in terms of also the course of their illness, treatment response wise, they look much more like bipolar illness than they do major depression. So it
Oh,
gets
hmm,
interesting.
very complicated in there, and that's one of the
Yeah.
major, diagnostic problems that comes up. But to answer your question, yes, we know a lot. We know a lot from neuroimaging. We know a lot from neurobiology. Very complicated, but a lot of really sophisticated and elegant science. I mean, it's
Yeah.
just in the last 10, 15 years, it's been remarkable.
Yeah, because a lot of the symptoms seem kind of opposite, between the 2, so I'm just
Right.
curious if maybe some of the mechanisms are, just the
polar
same
opposite.
mechanism, but other,
Yes.
each opposite ends of that mechanism for the 2.
Mm.
Yeah, I think very definitely so.
Okay.
It's the jury's out, but I think so. Yeah.
Yeah.
Well, I have to obviously you're very open with your own illness, and so I wanted to ask you about we talked about the symptoms, the things that can happen to someone who's in a manic episode, and I have to ask you about the snake bite kits. So
Uh,
you've talked about that before. I thought that was a very
uh,
fascinating, interesting manifestation of your illness.
uh, yeah, I think, and again, I think if you talk to anybody who's been manic, it's just it's different stories, same
Same
strangeness.
yeah,
Sure.
Yeah,
right.
right. So when I had gotten sort of mildly manic in high school and then severely suicidally depressed my senior year. And then I went bouncing around and never got psychotically manic until I joined the faculty as assistant professor at UCLA in the psychiatry department.
Mm,
And one of the things that happens to you when you're manic is you get very certain
Mm,
about things that may or may
mm.
not be true. I mean, and the word delusion comes to mind, but you also just get kind of paranoid and kind of convinced that you can do certain things or that you should protect people. So, one of the first things that happened to me when I got really manic was in LA, there are actually a lot of snakes. I mean, in fairness to my
sure.
psychosis, there are actually a lot of snakes.
Sure.
And so I had this sense that there was a major rattlesnake problem in the San Fernando Valley, pretty
Mm,
specific, but a lot of snakes. And so I went out and I went to a pharmacy at the same time that I was filling my prescription for lithium, my first prescription for lithium. I gave my prescription over to the pharmacist. And then I went around filling up my cart. And in my cart, I had like a dozen snake bite kits because I wanted all of my friends to be protected.
Mhm.
mm.
And so when I went to pick up my prescription, the pharmacist looked, at the
Yeah.
meds he just filled.
Put two and two together.
Like
Yeah, yeah, yeah. So it's a lightning mind. That's right. And and it's interesting. I gave one of the snake bite kits to my psychiatrist, and I was joking. Oh, maybe a year or so ago, there was an article about actually there was a snake infestation in the San Fernando Valley, and so I emailed him and I said, "I rest my case." This
You were
30
just
years
ahead of
later,
your time.
and he's and he's that's right. And he said, I still have that snake bite kit,
Oh.
which was
Oh
kind of
my
funny.
gosh. Oh, wow. That's so interesting.
Oh.
And so is it, if you get multiple, over time, multiple episodes, manic episodes, do they tend to manifest the same way for a person? Like, would it be the same for you if like maybe 6 months you had another episode? Or do you find that there are differences in those manic episodes?
Well, if you look at the old literature, one of the problems is that everything is compounded in this day and age by medication. So if you have a mood
Mm,
disorder and say you were depressed and then you took antidepressants, that can precipitate mania and can make you really, really agitated and give you a form of mania that you might not otherwise have had. So you might have
Mm.
had euphoric manias, which is about 50% of people get manic, or um, very paranoid and irritable manias, which is about the other 50%. So, so it, for the most part, the old literature where it was not complicated by medications, people were
mhm.
pretty consistent manic episode to manic episode in terms of the manifestations of the symptoms, how they came on, the first symptoms, and so forth, and the course. So there is a certain. I mean, if I stopped my lithium and I got manic, I could pretty much guess how that would play. Yeah.
Right. Fascinating.
Yeah.
Well, let's take a quick break and we'll be right back with Dr. Jamison. Hey, Kristen, do you know why a stethoscope is so hard to use?
Because there's no heartbeat in an eyeball.
That's actually a really good point, but
Uh-huh.
also the heart is quiet. The
Mm.
sounds are somewhat distant, and sometimes you're in a noisy environment and you're trying to listen to
Mm.
all the beeps and boops and whatever other noises there are in the heart. But With Echo Health's 3M Littman Core digital stethoscope, it's easier than ever. You get 40 times sound amplification,
Mm.
active background noise cancellation. Honestly, even an ophthalmologist could figure it out.
I also really could have used one of those before I had to do 10 minutes of CPR on you. It
Yeah.
leads to earlier detection, better outcomes, something that's definitely meaningful for us.
And we have a special offer for our U.S. listeners. Visit echohealth.com/KKH and use code KNOCK50 to experience Echo's digital stethoscope technology. That's EKO Health/KKH and use KNOCK50 to get $50 off plus a free case plus free engraving with this exclusive offer. All right, we are back with Dr. Kay Jamison. And what I want to talk about right now is something that has been on the minds of people in medical education and medical training, really, certainly during the pandemic, but even before that, for the last 5, 10 years, I feel like it's an issue that's been gaining a lot of attention, and that's just burnout, mental health, especially for young doctors, pre-meds, med students, trainees. And you have been at Johns Hopkins, for quite a while and have seen a lot of med students, a lot of trainees over the years. And so I'd like to get your perspective on the mental health of young doctors. You know, uh, how have you seen it change over the years? Is it getting easier to become a doctor? Is it becoming from like a mental health standpoint? Or are some of the challenges that new doctors face really the same ones we've been having for like 30 years? So I guess when you first started in your current capacity at Johns Hopkins, were you interacting with a lot of med students and residents?
Sure. Yeah.
And,
And
uh,
and I would say it's kind of sorts itself in two ways. One is mental illness,
mhm,
which is very real in house staff and medical students, junior faculty. And the other is, quote, burnout. So
right.
let me address that separately. In terms of mental illness, it's always been the case that there's been, since people started studying it, that there's a higher rate of bipolar illness in doctors.
Hmm.
There's a much higher rate of suicide in doctors, particularly in women doctors. And there's a much higher rate of depression. And so, one of the things we tell the medical students at Hopkins is, look, a lot of you are going to get depressed. That's just the way it is. I mean, it's a common illness. Most common manifestation is your age group.
Mm.
That's just that is, it's going to happen to a lot of you. So the question is, what do you do about it? And we will do everything possible to get you well. And we have every reason to believe that we will be able to get you well. But
Mm.
we cannot tolerate impaired doctors.
Right.
So you have to make the incentive to reach out for care instead of to curl up in a ball and avoid care,
Mm.
and also that you keep a wing out for your fellow classmates. You know what the symptoms are of depression, and so forth. So that's just sort of a thing. But people do, and people actually in the third year of medical school are more likely to get manic because they started their clinical rotations
Hmm.
and there's sleep deprivation.
Mhm.
Sleep deprivation is the single easiest way. If you've got the genes that are going to gear you toward bipolar illness, the single easiest way to precipitate mania is sleep deprivation. So people start going on their clinical rotations, stay up all
Mm,
night, and so forth. So you make reasonable accommodations, and you say, "Look, uh, if you're a resident, you're going to have to do the same workload as your fellow residents, but we're going to work it around so that you aren't, you know, being pressured by sleep problems and so forth." So I think that there's more recognition and more of an effort to reach out to medical students and house staff. It's still pretty quiet, but I mean, I get a lot
yeah.
of because I have been open. People come and say, "Yeah, how do you negotiate the licensing system? the
Mhm.
privileges system. How do you get around this and that? But mainly, how do you deal with being terrified it's going to happen again? You're
Right.
talking about your heart problems. There's a
Mhm.
certain terror probably lurking that
Mhm.
this is going to happen again. That's true for mania. It's true for breast cancer. It's true for so many things. So I think just recognizing that mood disorders, in particular, anxiety
Mhm.
disorders, perhaps less so, but um, substance abuse, that these are common things in doctors. And you could maybe you could wish it would be otherwise, but it isn't. And you're not going to have any medical students left if you start saying,
Yeah.
you can't have this and you can't have that.
Right. Right.
Or you have pretty boring students. Uh, I think burnout's much more complicated. I mean, the mental illness has been around forever, and
Right.
will be. And it's important to say this is an illness. It's not, you know, just putting stress in the background makes everything a little bit more squishy.
Right.
Um, with burnout, I think that I mean, you could say that well, maybe it's the admissions policy. Maybe we are attracting medical students that are more stress oriented, that are because they have these staggeringly high qualifications to get into
Right.
medical
Mhm.
school, and weird qualifications. I find it weird. I was on the admissions committee. I mean, I find it strange that there's. I mean, these people are. I don't know where they come from. They're brilliant. They're accomplished. They've all studied with three major cellists and written films, and in
Mhm.
addition to taking molecular biology majors. I mean, it's it's these are not normal. These are not the doctors of yore, right? Okay,
Right.
so these are, and I think there's something to be said, obviously for that group of people, but also for the doctors of yore who may have been a little bit more phlegmatic, a little bit more taking things as they come. I think another thing is the system's just insane in terms of epic and medical records and putting those expectations and taking away some of the delights of practicing
Yeah.
medicine that used to be there. And I think that that's something that's a real problem. And whether you call it burnout or depression is also another issue because
Yeah.
a lot of what gets called burnout is a discontent and is en- to a certain extent encouraged by the system because everybody talks about burnout all the time, right?
Mhm.
Right.
And everybody they do perhaps less to ameliorate burnout than they do to just put it out there that people are there's almost a weakness quality to it that that you've burned out.
Mhm.
Mhm.
So I think that's um, I think we should take it instead of just talking about burnout. That we should also talk about depression, but we should also talk about a system that encourages endless discussion of burnout, as opposed to, I mean, I sometimes talk to young doctors and I think, yeah, I can understand this is stressful, but try being a secretary who doesn't have any money, doesn't have a job she likes, and so forth. That's real stress. Is the people at community colleges. If you talk to students in community colleges, as
Mhm.
opposed to the Ivy League has a very special kind of stress. But boy, these kids that are working 50 hours a week and are the first kids in their family to go to college, that's a different kind of stress.
Right, it affects your life in a whole different way. How do you think the
Right.
pandemic factors in? Do you think, you know, in that case, now there's a bunch of, vicarious trauma and maybe some moral injury happening among doctors, right? As you're treating these people, and there's only so much you can do, or you're being prevented from being what you know they need, from doing what you know they need. Has that exacerbated burnout in a real way?
Or uncovered more mental illness.
Yeah.
Or I would say, I mean, I think with nurses particularly who
Hmm.
were there, hour in, hour out, hour in, hour out. Um, that you can just see it in the resignation rates. I mean, it's just really deeply upsetting to see that. And the question is, how do all of us reach out to fellow professionals and say we can try and understand what you've been through. What can we do to make a difference? I
Mhm.
think that's true for doctors, but less so. I think doctors had more independence in it,
Mhm.
and is so. I know that one of the things that our chief of nursing was giving a great talk, not too long ago, and she said, "You know what I will never ever do again in the rest of my life is keep a dying patient away from a family member."
Yes.
Because of COVID protocols, You can help you learn from things. That's all I
Mhm.
think is that you can say you can learn, but you also can expect that people will recover because I think if you play to people's weaknesses and fears and anxieties all the time, you perhaps encourage some of it. If you say it's been really difficult, it's been really hard, but you'll get through it. We'll all get through it, and
Yeah.
people are actually getting through it.
Mhm.
Well,
Yeah, maybe a little more, concentration on how to deal with those things when they happen, right? So first awareness, and I think that's what's gotten, better, maybe depending how you look at it, it's gotten more prevalent.
Yeah,
It's just awareness of these issues and talking about the issues. But it's like you're mentioning, it's no good to just sit and wallow in those feelings. We need to be preparing people and equipping people to do something about it to, get out of that place.
yeah.
giving people positive things to do as again playing to people's strengths as opposed to
Yeah.
playing always to this is the end of the world. It's not the end of the world. It's a bad epidemic, and it has been cost a million lives, and there's been incompetence and you know mistakes and terrible things, and it's driven this country apart in a horrible, horrible, unforgivable sort of way. But the emphasis has to be on how do you heal that, and how do you
Mhm.
get around that horribleness.
And that's something that you, as far as how to heal from a mental health, mental illness standpoint, something you touch on a lot in your new book. So I'd like to talk about that. Your book called Fires in the Dark Healing the Unquiet Mind. I think it's coming out in May, just a short time from now.
Well,
And
so by the time this airs, it will be
oh,
out.
yes,
So we
yes,
encourage everybody to go check that
absolutely.
out.
And so, can you give us a little bit of background of this book and why you wrote it and what people can look for?
I wrote it as kind of a love song to psychotherapy, but in a very general sense. I was interested in what what can we do, what do we do, what do doctors do, what do priests do, what do we do about psychological suffering. And I was interested in tracing it way back in time to thousands and thousands of years, indeed back to the Neanderthals, to seeing what people did when they were in mental
Oh,
pain.
interesting.
And through the war fields and the doctors who had to deal with trauma and had to improvise on the spot for hundreds of thousands of soldiers with shell shock in the First World War, to modern psychotherapy and to the combinations of therapy and medication, but also the use of the arts. I was very interested and always beholden to people, everything from King Arthur to Paul Robeson, and I wrote about lives of courage and beauty and how we have to build our own islands in order to survive. And it's up to us to build the islands, but it's the help of doctors and friends and family that make it possible.
Well,
That's
it's
super
just a
interesting.
yeah, fascinating subject for a book. I love medical history and seeing how things have changed over time, and it's
Yeah,
I
and I
think it's
think
just
maybe sometimes along the way we lose some wisdom that, maybe if we revisit, we can gain some of that back again in a new modern way.
yeah, exactly. Well, Dr. Jameson, thank you so much for joining us. It's really been a pleasure to talk with you. And again, that book is Fires in the Dark Healing the Unquiet Mind. And I think you can find information about you on your Facebook page, K Redfield Jamison. Again, thank you so much. We really appreciate your time.
Well, it was delightful to talk to you. Got a great program. Thanks. Thanks so much.
Oh, thank
Thank you
you.
so much. Take care. Okay, let's take a look at some of our favorite medical stories that were sent in by the listeners. It's fan story time. Here
Yay!
we go. So we have Patricia. Patricia says, recently I've had a prime lesson on, quote, never assume patients know how to take their medicine, even if they've been prescribed it multiple times. That's a good little lesson there. So patient came in, handed me their prescription, and it was for some suppositories. It's pretty common, even adults are prescribed those, especially when dealing with upper GI tract problems. I had them in stock, got the package, and was about to hand them to the patient when they asked for ones from a different manufacturer. I told them I would have to order a different generic, but asked what the problem with this specific brand was because I wasn't sure if it would make a whole lot of difference. The patient then asked me to look for ones that didn't contain paraffin. I was growing confused at this point. Paraffin,
The
like the wax,
wax.
right?
Yeah.
Because, and I quote, I've been prescribed these before and they taste so waxy.
Oh, dear.
Oh dear. I absolutely did not recover in time to stop myself from asking them, but how would you be able to taste them when you apply them through your. After which I was treated to the most stunning color show on their face, going from white
Oh,
to
no.
red. I guess that's when the
Aw.
realization kicked in. Well, they asked me to hand their prescription back. Before they could say anything, they bolted out of the pharmacy.
See,
So maybe
okay,
this could be a
now on
PSA for all
this
doctors and pharmacists the world over. Please don't assume patients know where their suppositories go.
and in this patient's
Yep.
defense, it sounds to me as though no one explained it to her well. Is it a her? A him? Do we know?
We don't know. They're
Them. No one
them.
explained it to them well enough. Clearly.
Well, I think and certainly, you know, don't hesitate to explain things multiple times.
Yeah. Check for
Of
understanding.
course, yeah,
Yeah.
yeah, yeah. It's a good lesson to learn, but also quite a story. That poor that poor patient.
I mean, it can't hurt you to swallow it, right?
It,
It's
it,
going in the same place
I have
eventually.
honestly no idea what the outcome of that. That's probably something I should have been taught at some point in med school.
Yeah.
What
I mean, it's
happens?
just the
Is it
other
okay
end of the same tube.
to
So,
consume orally a suppository? It is the same. It's a tube, right?
yeah.
Yeah,
I mean, stomach acid's going to do some things to it, but also
that might
so would
be.
the intestines.
Well, not
Not as
quite to the extent
harshly, I guess, but
of the stomach acid, but I like where you're thinking. Your
yeah.
head's in the right place, at the top of the tube. And so we got fan story number 2 from Misty. Misty says, in my intern year of pediatrics, I was doing my nursery rotation. One night, a fellow intern and I got a call from the nursery because a newborn had a fever. This requires an evaluation for infection, including procedures, and we had to get permission from the family first. Then the nurse told us that the mother only spoke Spanish. This was well before translators were readily available in our hospital. My fellow intern had some Spanish knowledge and volunteered to communicate the situation. Unfortunately, she knew conversational Spanish and not medical Spanish. She told the mother that the baby was Fumar.
Oh, no.
Now, you do know Spanish. Kristen here is a Spanish major in college, so
I
she's,
remember some of it. Conversational Spanish.
yeah. While she thought this would translate into hot or febrile, she actually told the mother that the baby was smoking. Is that
Barbecued
right?
baby. Yeah.
That's
Fumar smoking. Yeah. Whoops. Your
the,
baby is
the
smoking,
baby is
ma'am. I'm
smoking.
sorry to tell you.
The mother, what's the correct word?
Well, see, I don't know medical. This is the whole point. I don't
Fever?
know what it would be
Okay.
when it comes to, yeah, a
Hot,
fever.
caliente?
Again,
That-
that's going to be a
That's
different
gonna be
meaning than
okay.
you want.
Gotcha. I don't think I'll
Babies are definitely, that
Okay.
word does not apply to them.
I'll go ahead and stop there. Okay. The mother was truly surprised to
I
hear
would guess calor, like,
calor.
yeah, that means
Calor.
heat.
Oh, okay. Okay.
But I don't know. It's a guess.
You guys let us know. I'm sure
Yeah,
that we have a
someone tell
lot of
us.
people who actually know like medical Spanish. The mother was truly surprised to hear that her baby had picked up smoking on her second day of life. For, Fortunately, we found nursing staff who spoke Spanish and they were able to correct the misunderstanding. We joked about it for years afterward.
Oh, it's
That's a
hilarious.
good one.
That's a really good one.
Fumar. All
See,
right.
it's funny. I don't know why, but my mind didn't go to smoking like a cigarette. It went to your baby's on fire. Smoking.
Oh, that's good. Send us your stories. Knock knock hi at human-content.com. That was a fun episode. It
Yeah,
was
really
nice to,
fascinating.
man, talk about experience.
Yeah.
Like it's
Professional, personal,
yes,
everything.
yes. Dr. K. Jamison, just the wealth of knowledge she has on this topic, and having also just been in this field for so long and seeing the changes over time, and the reaction to mental illness and mental health, and how it's changed.
She brought
is-
up a good point too of, yes, it's good that mental health is in the conversation more today, but you don't want to forget that mental illness is its own thing within that. It needs different
true.
things than just, keeping yourself healthy, just the same way that physical health differs from disease
Mhm.
per se. So I thought that was a nice distinction to keep in mind as we continue these discussions. And
That's true. Because I talk about burnout a lot, and
Mhm.
I do a little bit on mental health in my videos, but I've never really thought about it that way. Like, no,
right,
we need to
sometimes there is
specifically
an illness happening
Yeah,
that
it-
needs
it-
a different kind of treatment.
right, and we need to talk about that in particular.
Right.
So lots of good things to think about, and just a very timely topic.
Yeah.
So thank you, Dr. Jamison, for joining us, and thank you all for listening. Do you have any thoughts about the episode? We'd love to hear what you guys think about anything from mental illness, our conversations on that, or about smoking babies. If you have any thoughts about smoking babies, we'd love to hear
Babies
it.
on the barbecue.
There's lots of ways to hit us up. Email us, knockknockhi at human-content.com. Visit us on our social media platforms. We're on pretty much all of them.
We're going to try to provide some value across the board.
I am frequently impersonated on social media, and so it was suggested by you
Yes.
that we have a presence everywhere, so that I don't get my identity
No
stolen.
one cares.
Okay, all right, let's move on. Let's move on. Also, hang out with us and our Human Content Podcast family on Instagram and TikTok at Human Content Pods. I forget that we're actually
Yeah,
people are listening
They want us
to
get
everything
on
we're
with it.
saying. Thank you to all the great listeners leaving awesome feedback and reviews. If you subscribe and comment on your favorite podcasting app or on YouTube, we can give you a shout out, like right now. At Jennifer Ellsworth 1226 on YouTube said, Dr. Glaucomflecken, Jonathan always has the perfect words. Look to Jonathan. I agree. Head nod to you. All right, keep sending us all your reviews and jokes and guest ideas. We love hearing that stuff. And stories, lots of stories. These episodes are up on YouTube every week on my channel at dglaucomflecken. We also have a Patreon, lots of cool perks, bonus episodes. We're there and interacting with you guys. Early ad-free episode access, interactive Q&A live stream events, much
I like
more.
to post pictures where you look silly.
Yes, we get it. We give you a lot of
behind the
scenes stuff.
Mm-hmm.
Yeah, to see like what this weird life is like. Patreon.com/Glaucomflecken or go to Glaucomflecken.com. Speaking of Patreon community perks, new member shout out to Juliet B. Thank you, Juliet. Welcome. And shout out to, of course, to all the Jonathans. Head nod to you all. Patrick, Brianna L, Edward K, Caitlin C, KL, Lucia C, Mary H, Mr. Granddaddy, Omar, Stephen G, Jonathan A, Chaver W, Jonathan F, Leah, Marion W, Mark, Roskbox, and Sharon S. Patreon roulette time. Drum roll, please. Shout out to Chaver W for being a patron.
I like
Thank
that you
you
ask yourself for a drum roll.
Oh, yeah, hey, don't rain on my parade here. That's my favorite part of
I
doing
said I
this.
like it.
Not really, though. We're your hosts, Will and Kristen Flannery, also known as the Glaucomflecken. Special thanks to our guest today, Dr. K. Jamison. Our executive producers, Will Flannery, Kristen Flannery, Aaron Corney, Rob Goldman, and Shanti Brook. Our editor and engineer is Jason Portizo. Our music is by Omer Benzvi. To learn about our Knock Knock Hi's program disclaimer and ethics policy, submission verification, and licensing terms and HIPAA release terms, you can go to Glaucomfleckens.com and reach out to us, knockknockhi@human-content.com with any questions, concerns, or jokes. Knock Knock Hi is a human content production.
Knock, knock. Goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen, or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts. Or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Help you subscribe, leave a comment below. Let us know what you think.